Welcome to a review of Chapter 46. In this chapter, we're going to look at issues that occur in the peripheral nervous system. Peripheral nervous system is composed of the spinal nerves, cranial nerves, and part of the autonomic nervous system. So basically, its job is to provide communication from the brain and spinal cord to other parts of the body, so the periphery. Guillain-Barre Syndrome is the first disorder of the peripheral nervous system that we're just going to discuss. Guillain-Barre is acute inflammatory disorder that affects the myelin sheath of the axon. If you go back and review the neuron and the axon, you'll remember that some of the axons have a myelin sheath on them, and this helps to process and conduct the impulses across all the neurons. So what occurs in Guillain-Barre is that the myelin sheath are damaged, and this acutely happens, and this is called demyelination of the myelin sheath of the peripheral nerves. It's a general weakness that occurs, and typically it's an ascending paralysis, which means it starts in the lower extremities and works its way up. The cause is not completely understood. It does typically occur in a younger generation, usually peaks at 55 years of age. There are multiple factors. They think that it is autoimmune related. There's factors listed on page 987 in table 46.1 that are thought to be factors associated with the development of Guillain-Barre: acute illness, GI illness, upper respiratory infection, viruses. Epstein-Barr virus is one of them. Vaccinations. In all the cases that I've ever seen, the flu vaccine they feel has an association with it. It's typically somebody who has recently gotten the flu vaccine that's at risk. That's why, if you recall, when you get your flu vaccine, on the little paper that you fill out, they usually ask you if you've had like Epstein-Barr. They'll ask you if you've ever had Guillain-Barre, because if you answer yes to those, they may be very cautious in giving you your flu vaccine. So, thought to be autoimmune as some kind of a response to some kind of an illness typically. It's an acute demyelinization of the axons. The myelin sheath is damaged, so the conduction of the impulses through the nerves cannot be conducted, so it causes an acute paralysis. It's an ascending paralysis that comes from the lower extremities up, and as it moves its way upward to the respiratory muscles is when it can be life-threatening. The patient may need to be intubated, because if they cannot control the muscles of their respiratory system, they can go into respiratory distress. This is diagnosed by doing a complete history of the patient, questioning them if they're starting to have these kind of vague symptoms of being paralysis, paresthesias, like a burning, stinging, prickly feeling, kind of vague symptoms. You're going to start asking them questions if they've had a recent illness in the past 2 to 4 weeks, immunizations, and what kind of immune system issues that they've had in the past. A full neuro exam would be indicated here as well. You're checking all their cranial nerve responses, orientation, deep tendon reflexes, things like that are going to also help to diagnose this. There are no definitive tests to confirm Guillain-Barre. They could perhaps, though, do a cerebrospinal fluid check for protein, which could indicate the likelihood of Guillain-Barre. The protein in the cerebrospinal fluid doesn't show up till 1 to 2 weeks after the illness, and it peaks at 4 to 6 weeks, so it's not always the best definitive way to determine if someone has Guillain-Barre, but it could be something that they might use. Make sure you review the lumbar puncture procedure to obtain a cerebrospinal fluid sample. This is where they're going to put a patient on their side and aspirate with a needle fluid out of their spinal column in the back. So it's a little bit scary for people to have a cerebrospinal fluid sample obtained to have a lumbar puncture. Our job as a nurse is to support that patient, hold them, help them to lay very, very still. They have to be able to lay very still, as you can imagine, for this procedure. And then typically the needle is inserted between the third and fourth lumbar vertebrae after the skin is prepped and there's a local anesthetic placed. The patient may feel some discomfort but should not feel pain. And they need to let the provider know if there's any kind of shooting pain or tingling sensation right away. There's typically guidelines for per agency regarding bed rest and remaining flat after a lumbar puncture, so make sure you're aware of that. They typically do decrease their activity and have them lay flat for a couple hours afterwards. Obtain vital signs, of course, and complete neuro checks afterwards after the lumbar puncture. Encourage patient to increase their fluid intake. And just monitor for any complaints of headache, nausea, vomiting, because it is a little bit of a risky procedure. They're at risk for causing some damage in their cerebrospinal column, so just be really observant. And monitor the site. They'll put a little Band-Aid over the site, and you would just need to monitor that site for any bleeding or drainage or anything. This is just a visual of how Guillain-Barre works as an ascending paralysis that occurs. Starts at the feet and works its way up. And this is temporary, and this is acute. One thing to remember about Guillain-Barre, it does reverse itself, this paralysis does, but it can take a long time. It can happen over several months, but it is reversible. They do get better. There are different variants of Guillain-Barre. These are listed on page 988 in your book and table 46-2. And just note that the most common clinical pattern is the ascending, so I would focus on that. Just have a knowledge that there can be some differentiation of it that are a lot less common. Guillain-Barre in itself is very uncommon, so it's not like a large amount of the population is getting this, but it usually happens in younger people. And it's typically autoimmune related. So I already reviewed the lumbar puncture. Just make sure you review that test and how to manage a patient that's having a lumbar puncture. Lots of different reasons why people might have a lumbar puncture, but in this case, it could be just to kind of check for protein in the cerebral spinal fluid to help diagnose Guillain-Barre. Priority nursing care. These people are at risk, like I said, of having a respiratory problem as the paralysis moves its way up to the respiratory muscles. So you have to consistently monitor that patient to determine if this is happening or not. Typically when someone has been diagnosed with Guillain-Barre, they actually will put them in the intensive care unit so that they can be monitored very closely. And usually it's that airway management that's the highest priority. So they're monitoring them for any air hunger, any dyspnea, any abnormal breath sounds, any change in their oxygen levels, any cyanosis, those things that are indicating that the patient is now having any paralysis to their respiratory muscles. Keep their head high, all those things that you need to do to support respiratory effort is what you're going to be doing as a provider, as a nurse for this patient. Keep their head up, suction them if needed. Just, again, monitor them for any kind of a deteriorating status. You can encourage them to use their incentive spirometer, administer oxygen as needed, those kinds of things. As far as pain management, they actually can have some pain even though they do have some paralysis, but they have some very difficult to manage deep muscle pain, aches, and muscle stiffness. It typically happens a lot at night, and usually it requires, it's such a deep muscle pain that it requires like pretty strong meds. It can be opiates, perhaps morphine. Sometimes they give them PCAs. And they can also use things like gabapentin, which is for that neuropathy pain, because some of their pain is very similar to that. So just make sure as a nurse that you're doing things to monitor for their pain levels and to treat it appropriately. And you can do things that are non-pharmacologic as well, such as giving them, massages, heat, ice, safely, relaxation techniques, hypnosis, and distractions, and things like that. You do have to support them emotionally. A lot of times it's young people who were, maybe a week ago were functioning adults and then are now in the hospital very helpless and paralyzed. So one of the things is communication. They can actually, especially if they get intubated because of their loss of ability to breathe, they're going to lose their ability to communicate. So make sure you support that by using different modalities to help them to communicate, like boards, letter boards, things like that. Nutrition-wise, again, you're going to have to support that if they're no longer able to control their muscles of their throat to be able to eat and drink. They're going to get IV fluids if needed. They may need a G-tube temporarily. Something, and it could be something also as TPN, which is total parenteral nutrition, which gives them their nutrition through their veins for a temporary time so that we can make sure that they get the nutrition they need if they're unable to have PO intake. This is a patient that is immobilized and hospitalized again, so other nursing management is, prevention of any DVTs, prevention of pneumonia, all those supportive measures like you would any other patient that's in the hospital too. The treatment for Guillain-Barre is called plasmapheresis. Plasmapheresis is kind of similar to like dialysis, basically, and actually it's typically run by dialysis nurses, but they will take their blood, remove the blood, and as they remove the blood, they will remove the plasma. They'll separate it. So they selectively separate the plasma, thinking that it will remove the antibodies that are causing this autoimmune response. And they replace the blood back without the plasma. Plasma will usually replace itself, or they'll actually give them substitutes such as albumin, which can provide the same thing as plasma. They also can overload a patient, so they don't typically give a lot of the plasma back. Typically, they want to get it started within a several days after the onset of illness. And they'll run this a couple times a day. They can give them 3 to 4 treatments, and they found that it decreases the severity of the Guillain-Barre. Just taking care of a patient that is undergoing plasmapheresis, nursing interventions is just monitoring the patient's eyes and nose, weighing the patient before and after the procedure. And sometimes they have a shunt, which is sort of like a dialysis shunt that they might use to do the plasmapheresis. This is just a pretty much the same list that we already discussed regarding nursing care of a patient with Guillain-Barre. Again, just want to kind of focus on, of course, the cardiac dysfunction. They have a risk for arrhythmias, and monitor their vital signs. A lot of different things can occur, like hypotension, especially if they're getting plasmapheresis. So just, again, they're going to be monitored very closely because they're probably going to be in an intensive care unit. Again, that pain and communication and just providing a lot of psychological support. And then improving mobility and preventing complications, I think I talked about. But I just want to go back to the immobility piece of that. They can, if you remember, the longer somebody is immobilized, the more flaccid their muscles can become, and they can actually atrophy. So there's going to be a lot of physical therapy involved, and also some passive range of motion continued, and make sure that it's done so that we maintain their mobility as best as possible. Because, like I said, it's reversible. Guillain-Barre is reversible. It can last over several months, and the patient is so at risk for being weak, and they're going to have rehab afterwards because of the time that they're immobile. So the longer somebody's immobilized, the more likely they are to have, weakness in muscles and contractures and things like that. So as a nurse, we want to make sure we do everything we can to maintain their muscle tone, like passive range of motion, get physical therapy involved and things like that to help maintain them as much as possible. Okay, moving on to myasthenia gravis. Myasthenia gravis is even more rare than Guillain-Barre. Again, it's an thought to be autoimmune response, and it affects the acetylcholine. So it affects the acetylcholine receptors. And remember, we talked about acetylcholine is what initiates the activity of voluntary movement. So this typically happens. It's an out-of-body attack against the acetylcholine receptors, so it causes muscle weakness, many different varying degrees of it. It can cause anything from mild disturbances of the ocular muscles to rapidly developing generalized weakness that could lead to respiratory failure. And it has remissions and exacerbations, so it can get worse, get better, get worse, get better, depending on the patient's immune response. So one thing to remember about Guillain-Barre and myasthenia gravis is that they both can become life-threatening, and so priority monitoring by the nurse is airway. They're finding that myasthenia gravis is common or more common in people who actually have a thymus gland disorder. A lot of times if they have a thymus gland tumor, they are at risk for myasthenia gravis. They're finding there's some association between that. They also feel that there's an association between hyperthyroidism and myasthenia gravis. So in diagnosing a patient with myasthenia gravis, they'll also check their thyroid levels in their thymus gland and their thyroid gland to make sure to determine if that's the cause or the source. So the slide's a little bit difficult to read, but it's a good visual of all the signs and symptoms of myasthenia gravis. And it's typically is kind of a slow onset, and they're kind of vague symptoms at first, typically. But you kind of, in diagnosing this, you kind of start asking your patient about history, and if they report that these symptoms come on maybe after a stress in the body, maybe after exposures to vaccine or any environmental extremes in environmental temperature can cause this to come on as well. And so what will happen is they'll start getting these they'll get very, very tired. In the morning they'll be okay, but as the day wears on, as they work and are busier, the symptoms become worse. And that is kind of depicted in this picture here, where at the beginning of the day, they feel fine, but then they start to develop the diplopia and speech slurs later in the day. So this picture here kind of shows that most of the weakness occurs in the face, with the swallowing muscles, the chewing muscles. They get drooping eyelids, which is depicted in this picture here. And so it's a lot of the muscles of the face is where most of the weakness is. As you see, 95% of that is in that red area. 60% is in the shoulders and arms and the waist, and then 30% is the hands. 10% is the chest. So That's, of course, that's the area where we're really worried about as far as respiratory muscles. But remember, up here in the face, we're worried about those swallowing and that airway that is involved in that area. So really watch them for any signs and symptoms of any weakness and loss of the airway. This is another pretty definitive symptom that kind of helps us diagnose somebody with myasthenia gravis. They have this difficulty with this, they can't hold their head up. So they kind of hold their chin on their chest. Just have a really hard time since they can't control those muscles as well. So diagnosing a patient with myasthenia gravis can be a little bit tricky at times, and sometimes it gets missed. It gets, just thought to be a lot of different forms. A lot of these neuro things are somewhat vague, so they are somewhat difficult. A primary care physician might treat for something when the symptoms first occur, but then typically they get referred to a neurologist for a definitive diagnosing so that they can do very specific tests. And then, like I already said, they will check their thyroid to see if there's any kind of related issue there. And then remember, we said that it's an acetylcholine receptor deficiency because the antibodies attack that receptor site. So sometimes they'll do a test for antibodies. It's just acetylcholine receptor antibodies to help determine. A positive antibody test would confirm the diagnosis of myasthenia gravis. They'll do some other neuro tests, repetitive nerve stimulation, which is just kind of stimulating the nerve to see where the weakness is. Electromyography is another one that is like a stimulating test to determine muscle weakness. A specific test for myasthenia gravis is Tinslin testing. And it's basically Tinslin testing. It's like a challenge test. They will give them a dose of Tinslin and monitor to see if it is helpful for the weakness. So it's kind of a little bit of a tricky test because Tinslin inhibits the breakdown of acetylcholine in the postsynaptic membrane, and it should increase the availability of acetylcholine for excitation of postsynaptic receptors. So it makes the acetylcholine more available. So if we give a patient Tinslin, it can help us determine whether the myasthenia gravis is related to something called a cholinergic crisis, which is too much cholinesterase inhibitor drugs, or myasthenic crisis, which is too little. So basically, it's sort of a differentiation test. And we'll talk a little bit more about myasthenic crisis and cholinergic crisis related to myasthenia gravis. And basically, it's about the cholinesterase inhibitor drugs are a first-line treatment for myasthenia gravis, but there's side effects for these. And they have to monitor the levels of these drugs, and there can be day-to-day variations. And we'll talk a little bit more about these drugs in the next few slides. This is just a summary of myasthenia gravis as far as the pathophysiology, clinical manifestations, and such that you can review. So these cholinesterase inhibitor drugs help with the levels of acetylcholine and the transmission of acetylcholine, because remember, in myasthenia gravis, that's the problem. The receptor sites are damaged, so we need some acetylcholine here. So that's how these drugs can help. There is a lot of side effects, like I said. They need to take this 45 minutes to an hour after taking, they need to eat 45 minutes to an hour after taking to avoid aspiration. And there could be GI side effects, so they just need to make sure that they take it with some food. So potential side effects of these cholinesterase inhibitor drugs is sudden weakness, which is a cholinergic crisis, which means that they're getting a cholinergic crisis and an acute exacerbation of muscle weakness caused by too many of these drugs. And then your myasthenic crisis is an exacerbation, a flare-up, or worsening of the symptoms caused by not enough. So it's kind of a tricky balance of not too many, but enough. So there's a table on page 994, table 46.3, that talks about the characteristics of myasthenic and cholinergic crisis. You don't really need to memorize what these are, but just be aware that these are side effects of these meds and that the patient does need to be monitored very closely. And if you do notice that a myasthenic crisis is something that is an emergency situation, because if they have this increasing muscle weakness, that they, they could become very, very sick. And we'll talk about these crises more specifically in the next slide. This is a Tinslin testing slide. Like I said, just know that Tinslin testing is very specific to myasthenia gravis, and they just monitor after they give the med. They monitor for improvement 30 to 60 seconds after it to kind of differentiate the diagnosis of myasthenia gravis. So it lists the cholinergic crisis and the myasthenic crisis. The provider does need to determine the difference, and the Tinslin test can help us determine which one it is. And just notice that in both of them, the top thing that you do is maintain respiratory function. And then you have to determine which one this is, because you have to either withhold the med. You withhold the med in both of these crises. However, in the cholinergic crisis, you may need to give atropine to dry up secretions. Remember, that's one of those anticholinergic drugs. So it can, it's a more of a cholinergic drug to dry up the secretions, atropine. And then, of course, with the myasthenic crisis, you're going to hold the drugs as well. But then what they will do is gradually reintroduce the drugs at lower dosages and just monitor the patient very, very carefully. Management is very similar to Guillain-Barre. Again, immunosuppression, so they will give them meds, maybe autoimmune, like prednisone can be given to decrease the immune response, just as in any other autoimmune disorder. And then there's some IV things that they can give, like IV immunoglobulins, to decrease the immune response. And then, that respiratory support, again, because Guillain-Barre and myasthenia gravis both can be life-threatening as far as respiratory and airway issues. And then, again, you have a young person who is having all these different manifestations that can cause weakness, can cause a lot of self-care issues, and so you got to help support them through that. And in myasthenia gravis, you have the difficulty with the vision, the double vision, and the drooping of the eyes, so you're going to have to make sure you maintain care of the eyes if needed. Again, they could end up having some thymectomy surgeries due to if there's an involvement of the thymus gland with this disorder. There's a great table on page 995. It's a chart, actually, 46.4. It talks about best practice for patient safety and quality, improving nutrition in patients with myasthenia gravis. It's talking about weighing them, monitor their food intake, and watch liquids because they can aspirate because of remember, the weakness is mostly in their face. And swallowing muscles, cut their food into small bites, all those different interventions that you can do to make sure that they don't aspirate and make sure you maintain their nutrition. So these are things that can cause exacerbations, because remember, myasthenia gravis can have periods of exacerbations and then periods when they get better. So to help them, decrease their number of exacerbations. Just make sure that they do things to avoid infection, stress, surgery, any kind of things that are going to stress their immune system. Make sure they get enough sleep, they avoid extreme temperatures, emotional extremes, things like that, and monitor for the importance of compliance. That concludes the video presentation for this chapter 46. Make sure you review the case study and the questions to help you understand and assess your learning.